Hello, my name is Doug Rogers, and this is the Counterweight podcast. I'm excited to be joined by my guest host, Russell Stover. And I don't know if I'm more excited that we have the luminary Dick Flanigan on the show to share his thoughts. I think many of our audience know who Dick is. They've interacted with Dick, they've worked with Dick. But if you don't, I'm not going to go through his full resume. Really, the big thing I would highlight is he's currently the Chief Executive Officer for Digital Health KC. And I think the title belies really the heart and soul that he is bringing to this community and helping build an ecosystem, not just in Kansas City, but more broadly around how we go affect change in the digital health space. That is the tip of the iceberg, Dick, in terms of what your career looks
That's
like.
good. That's enough.
But
I'm
that
not
is
looking
a
for a big commercial here.
That's right. So, welcome to the pod. Why don't you just tell our audience a little bit about yourself? And I think the first thing we're going to talk about is you're going to give a view on the journey and where you see digital health KC going based on some of the conversations that you've had.
Well, first off, Doug and Russell, thanks for including me. And it's an honor to be on the podcast. We've done some joint podcast work before with one of our
Yeah.
Health 201s, and they've been really well received. So I'm very happy to be part of this. Look, I'm a information technology and healthcare guy, 13 and a half years at IBM and almost 28 years at Cerner, really focusing on this intersection of healthcare and IT. I am more excited now about the prospects, the impact that information technology can have on improving lives, and something that I'll talk about a little later, this trifecta of patients wins, provider wins, and the payer needs to win too. Okay. So I think we're finally at a place where the data is flowing, the transparency is improving. We might actually be able to craft a new bargain, and I hope we'll get into a little conversation on that. Did a wide variety of things at Cerner. I'm one of these very fortunate Cerner folks that got to run different business units, interact with folks around the country and around the world. We lived in France for a year, so gained perspective that there are some other really cool ways to do a national health system. The United States, I think, has its incredible strengths, but we'll talk about some of the things that make it challenging. 3 years ago, with the transition out of Oracle and the acquisition of Cerner, it was a great chance to exit gracefully, and I'm thankful for my Cerner Oracle colleagues for that. And had this idea along with Maria Flynn that Kansas City had something really special, particularly around talent and this rich workforce. And so we decided to really see if we could make a go of it. And we've been into that 3 years. And I got to tell you, I love working with this community. I love showcasing the heartland as a place for innovation and impact in healthcare, and just having fun and trying to grow our companies and grow our workforce and continue this great run that has really defined the Kansas City region for health IT. That's me.
So, Dick, I have to admit, I think the 3-year arc is a good view to look in, and not to say that there wasn't an ecosystem per se before Digital Health KC, but just my own perspective in coming to the events and participating, what you, Maria, and Liz and the entire team have done, it really feels like you've put your arms around and organized an ethos and a connectivity that wasn't there before, and elevated the energy level that there is really real possibility you can go build meaningful digital health companies from scratch in the heartland, and that you don't have to exit and go out to the coast. So 3 years in, how do you feel about it? What do you feel like the next 3 years looks
First
like
off,
for this?
thanks for your active participation in the community. That's number one. And then two, I would say the ecosystem has, when we first were putting this together with Maria, we had talked to one of the great thinkers in regional economic development. And we described to him, we had all these companies and we kept finding more. We had all this talent. We had this combination of three really big, important companies with NetSmart and WellSky and Oracle, and just an incredible range of early companies and a nice grouping in the middle. And he kind of listened to us very politely. And then he stopped and he said, I get it. You have a cluster hidden in plain sight. And Maria and I were like, yeah,
Yeah,
that's what we have. We have a
that's right.
cluster. But clusters sometimes, don't have a God given right to exist forever. Like you might have a cluster around Southeast Texas for oil and gas, and that's a natural occurring phenomena that has to be mined and explored and all those kinds of things. In our case, we have a cluster that's probably corporate driven, not economic development initiative by a city or a county. And that's the opportunity to really build on what is not naturally occurring, but one that occurred because of the hard work of not just Cerner, but a lot of other companies along the way. And that's been kind of fun to rediscover who those companies were and who those innovators were. So the tail of the tape, 3 years is a good mark because Liz, and I give Liz an enormous amount of credit on this, we just pulled together a grant request for a MOBEC, Missouri Technology Corporation, kind of supporting our infrastructure for years going ahead. And we got a big federal grant and a Kaufman match a couple of years ago. And that brought $4 million into the ecosystem to support this. Doesn't last forever. So we're doing our reporting. I'm probably at a point of maximum knowledge
Yeah.
of impact right now. And so here,
Mhm.
the storyline is this community needed some catalyzing.
Mhm.
As you guys know, you guys live in different parts of the metro area. We are a very large geographic metro area with, in terms of population, relatively low density, which means the guys up in Liberty are unlikely to run into people from Lee Summit, from Olathe, from Leawood, from Overland Park. And yet, when we run an event in Overland Park or in downtown Kansas City or up in North Kansas City, it is amazing. People come out of the woodwork. We always have new people, but I will tell you, I think the 30 meetups we've done and the 22 healthcare 201s, there's always a documented magic moment. There's always an investor, a consultant, helper, a go to market person with a founder, and they're like, hey, talk to John Travis. He's working all over. You want to talk to Chris at Matchrate? He's already solved this problem. Or we get them connected to somebody that's in the service providing, and that is the gratifying part is sometimes in an ecosystem like ours, you just got to mix them up, put them in the same room and let the magic happen. So we were at KU has also in this time frame built something called the Digital Health Collab.
Mm.
That's such an important attribute to be able to begin pulling the innovation out of the KUs and the Children's Mercies and St. Luke's and UMKC, and to not just license that, but actually to commercialize it into entrepreneurial companies that can grow and employ people and continue to make a difference. So, Doug, what we'd observe is when we get people together, the first thing they say is, thank you for getting us together,
Mhm.
right? So, yeah, that's a pretty low bar. And some people have said, oh, I've seen Digital Health KC. You guys are just a big social network. And I'm like, thank you. You think this is
There's
me?
value in that. It's not
I
the
think
only
it's a
thing.
compliment. Now, I
Yeah.
don't like the word just
Yeah. That's
because
right.
in addition to that, we've developed some great programs. We have a program called Market and Customer Connect. We have Investor Connect. We're launching a new program called Idea Connect for that
Mm.
very early stage founder that's got an idea, wants to know how to navigate the ecosystem. We attracted 66 unique investors to come to Kansas City for Digital Health Day. We had We're activating Garmin. Garmin announced 2 days ago that they're sponsoring awards within the KU ecosystem for people that want to connect physiologic monitoring data with EMR and other observed data to find, are there hidden clues in terms of patient disease, patient recovery, health, wellness, outlook. We are so fortunate to have Garmin. Garmin is, and we anticipate with Garmin, they haven't completely agreed to all this yet. We had some fun in the conversation with KU, but we think there should be a center for connected health. We think Garmin is world leader in that sensor technology, efficiently using batteries. We've got great informatics professionals at our universities and at Children's Mercy. So what we see is it all coming together. And I'm excited because it's not about what Digital Health KC does. We're like stirring the pot. Okay. We sometimes actually provide a pot, but what's in the pot is you all. It's the people that are listening to the podcast, the people that have engaged with us. And, to me, that's the most exciting piece. And in fact, Dr. Tony Sung, who is a researcher, a physician at KU, and does a lot of work on follow up on transplant medicine and post cancer treatment, he said, hey, I really appreciate it. Last year's digital health, I was introduced to Garmin And here we are a year later with a strategic partnership to activate Garmin into our research community. Wow. Okay.
That's right.
That's not
That's
just because
amazing.
of, but it's about collisions. It's about putting people in a place where they can interact with their colleagues, share ideas, and then when we see companies like Triley and CarePilot and
Mhm.
Setworks and Onyx and all these other companies raising money and Community Care Link and all these people that are impacting, and again, moving things into the marketplace at great speed, I get really excited. I'm sorry, in case you couldn't tell. Maybe I can dial this back a little bit. Okay.
I don't think you should. I think your phrase, these collisions, that's not just what digital health KC is about. You've got all these other programs, as you rightly observed, but there is tremendous value in those collisions. Dick, I remember I was at a coffee shop with Matthew Swindells. We were out at a client site. For those in the audience, Matthew came over from the UK, ran the healthy intent population health business for Cerner for a period of time. And he made the observation about you could be on the coast and sitting next to somebody, and they have this idea, and that there's all these collisions. And I'm listening to him, I was like, that's what I want in Kansas City. And then to your point, I've started coming to these digital health KC events, and it is this magical unlock. You don't know the conversation you're going to have, but invariably it's a conversation that introduces you to somebody new, introduces you to a new idea, or advances something that you hadn't been able to advance before. And there's a ton of credit for that. So I love the momentum that is coming out of this, and we're excited about what the next 3 years will hold. Now, I'm going to juxtapose that. So you leave Kansas City, which I would like to say is the mecca of the world.
Yes.
Everything is up to date in Kansas City, as they say. But you went out to Las Vegas, and I think you and Russell talked about this, but we'd love your insight. What did you see from health? And is there anything that, as you come back into Kansas City, like, oh man, there are some trends that either we're building on or that we're going to take advantage of? Just I'd be really curious your perspective of coming out of that conference.
Well, yeah, one, you're tired. And even though it's not like Vegas is assaults every sense at once, and yet HLTH Health is actually a very good location for bringing people together. I would characterize it as a partner investor, conference more than I would a bunch of buyers coming together. So that's my first observation. It's a very navigable conference. They do it at the Palazzo Venetian. What that means is, like, if you need to be somewhere, you can get there in 5 to 7 minutes versus what we've all seen at HIMSS and consumer electronics. I mean, it might take you a half hour to go find somebody. So there's a real accessibility. And I think why that's important mentioning is what you're actually doing here is you are reconnecting and networking with people. So accessibility becomes pretty critical. Liz and I, so Liz Schaefer, who co-leads the Digital Health KC, Liz has been a great partner doing wonderful work. So we're out there and we stood in this intersection. I was waiting for someone. And I think there were 9 people that happened, just happenstance, crossed this intersection where we had a meaningful conversation. That's why you go to these things. In fact, in filling out my survey for HLTH, I was like, for me, it's networking number one. Two, it is where I can get a very rapid pulse on what others are thinking about in the industry. And health does a really nice job of these shorter presentations and many of them, and they do a lot of showcasing of companies and ideas. So I would say the format, I think these guys have got it about right. No big, yeah, there's booths and some of the booths are big, but there's not this overwhelming show effect. I think it's much more intimate, more meaningful. So, kudos to the guys that put that on. Now, what did I see there? Number one, it's the AI show.
Mm.
As anybody that's been to HIMSS over the years as the long term, and I've gone to HIMSS for 33 of the 35 years I've worked in health IT, and I got to tell you, it's always had some overriding theme. We went through the chin or the health, information network phase. We went through the pop health phase, the data and analytics phase. We are so solidly in the AI is everything phase.
Mhm. My gosh, yes.
Yeah. So what I was struck by, first off, there are big names there, right? Google's there, Microsoft's there, the names you'd expect. But there were companies there, like there is at every show, but there was an overwhelming number of early stage companies, either at their stand up booths or in small booths or part of economic development units. And I don't think there might have been, I didn't see anybody that didn't have an AI message. Okay. And I think that, and a couple of the LinkedIn commentators noted that they all look the same. But honestly, that's the way it's been. The pop health, when, it was the same in data analytics, the
That's
same
right.
it was the same in safety and quality. We all look the same because we're trying to match the themes of the buyers.
Mhm.
So AI was the theme, AI was the messaging. Everybody was AIing everything. Now, as someone who's had a bit of industry experience and walked through a lot of these, there were some that I was like, so I don't think you're going to be here next year. I don't know your burn rate, so I don't know
Yeah,
any background here. But man, you are threading a needle on a very small TAM opportunity. So, but a lot of great people, a lot of people really committed, I think, to getting healthcare right. They have a great food is medicine pavilion. They had an oral health pavilion, which I
mm,
love hearing about that. A lot of mental health, wellness, the things that you hear dominating, the normal conversation. So overall, I thought actually, it's probably one of the best ones I've been to. It's a little more compact, it's a little more focused, but at the same time, and we've said this at HIMSS and other of these shows, about half of these companies will not survive the fallout over the next year or two. And that's okay. Healthcare has a very rich forest floor, you know,
mm,
ecosystem. There's a lot of light shining through the trees. The forest floor is blooming with ideas and companies. Just like in the forest, they're not all going to become big oak trees, right? They're not all going to make it. But I think they all have an influence. And I think I was impressed. And for those of you that are going to pick one business show, it's Becker's, HIMSS, in my case as well, ACHE, and a few others. I think Vive is more buyers, true buyers from the health systems because they partner up with Chime and work really hard to get Chime, the HIT and CIO execs. This feels much more investor partner
yeah,
networking type of show. But overall, worthwhile, very well run show and good to go. So I enjoyed it.
yeah.
Sorry, Doug, I didn't mean to cut you off, but Dick, I
No, go
think
ahead, Russell.
we spoke a little bit yesterday, and this is again one of the themes that I had seen on LinkedIn. Obviously Doug and I didn't go, but I think it was Christina Farr who kind of commented that she was starting to get a little bit concerned as well about who's going to be responsible for bearing the cost of all this innovation. And we talked about that a little bit. There's some specific examples of types of problems that are being solved right now with AI that you can call it zero sum, where, one party seems to benefit and another doesn't benefit at all and bears the entire expenditure. The example that, I think about a lot is some of these rev cycle companies that are responsible for, or that are, taking control of the coding process. And, it's a great benefit for a provider, but ultimately the payer kind of carries the burden of that new workflow. And there's other parts of this that are completely different. Obviously, Mark Cuban was there talking about cost plus drugs, which is really about cost reduction. But I think that there are certain circumstances that are a little bit concerning. And I wonder what your thoughts are on that.
Yeah. Well, there's a couple different threads maybe we can pull on here. First off, when I present to masters of, MHA students, and I do a lot of things where I start off with the triple aim, and
Hmm.
I break it down into 6 words, which is really 4 words: better health, better care, better value. And I think we should wake up every day as healthcare and IT professionals who think about systemness of a thing that is not really a system. But that doesn't mean we can't improve it. Okay. Even though this is not a reformable system in the classic sense, it doesn't mean we can't make real progress around the many, many edges of this, system or pseudo system. So the example I would say to you is better health, better care, better value. In my first 10 years at IBM, I did a little bit of healthcare, but I did manufacturing distribution for a tranche, and then I did finance, insurance, and securities. And if you were to look at the value propositions for the 70s, 80s, and 90s, it was overwhelmingly that computerization, digitization, information technology was going to create a far more efficient industry, reduce costs, improve access, and create innovation and growth throughout. Really, I think mission accomplished. I mean, I think we continue to see this. IT did not eliminate jobs, IT changed jobs. And I
Hmm.
think we have to have that attitude going forward. So, why is it that this industry has not met this very basic tenet that we lived with in every other industry, that it should be better this, better that, better value? And I've written an article on this years ago, and I looked at the differences in France, and I get it. It's complicated. Humans aren't widgets. I mean, I can go down that whole list. I get it all, guys. But we have built a health system that we cannot afford. And the more we wake up to it as Americans to understand that there are many things that track in terms of the debt, but the number one trackable thing in the deficit in the
Hmm.
United States is rising healthcare costs. Why? Because the government pays nearly half, depending on which year you look at, of all healthcare costs coming through Medicare, Medicaid, funding to the states, children's health insurance, payment for veterans, payment for military, payment for, federal workers and all those things.
And tax subsidies for
Exactly.
employee-based healthcare. Yes,
Sure. And which we've done for,
that's right.
since World War
World
II.
War One. Yeah, World War Two. That's right. Yeah.
So we have built a system where you can have as much of it as you want because for the most part, somebody else is paying for it. And that was kind of the model. So we displaced this whole, I get value from it as long as I don't have to pay for it. Okay, so put that one off to the side for a sec. We just have to understand as Americans, we've built a system we cannot afford. Now, how do we reform that? I mean, we could think about Medicare for all. We could think about lots of other things, but I have a couple of starting points. First off, and these are Dick Flanigan principles, okay?
All right.
Number one, healthcare innovates at the speed of trust.
Mm-hmm.
And so we can pretend we have all these ideas to reform the system, but the reality of it is we make change because patients, providers, and payers trust that the systems, the solutions we put in place will improve their operation, protect privacy, hopefully improve quality, safety, and better patient outcomes. So if we don't trust, nothing happens in the system. And I think we're not at a period of high trust, even though I know that's a cyber framework. Okay. I don't think we're at a period of high trust. I think we might be at the opposite end of the trust curve, that people don't trust. So I think the first thing we have to think about is how do we rebuild trust in the system? To that end, I want to call for a payer provider truce.
Hmm.
We are vilifying the actors on the stage. I mean, I don't know what's a wake up call when you assassinate the CEO of a company and people cheer about it and people are free Luigi kind of stuff. I mean, we have got to be crazy. Now, embedded in that is deep concern over the affordability and the access. And I get it. I get it. But we have to remember in America, we outsource no to insurance companies. We love to blame the insurance company, but guess who the insurance company is? It's our employer. It's our government who doesn't have the courage. And I'm not, I get this. Okay. We don't want to have to tell our employees that they don't get this treatment or that treatment.
Mm-hmm.
So we outsource no. Why? Healthcare is complicated. Networks are fragmented. We need somebody in the middle to manage that for us. But more importantly, we have to have somebody take the heat when they say no. And we get angry at the insurance company, and the insurance company's like, well, honestly, when your company bid benefit design, they didn't want that organization in the network. When that
Yeah.
company set up the payment so they could keep it affordable for you, they didn't give you a wide open panel. So you can blame the insurance company for saying no, but guess what? That was in plan design. So interestingly, in these big battles that are going on between payer and provider, Johns Hopkins, UPMC of a few years ago, and Highmark, and these things play out, but Kansas City, St. Luke's United went through this some years
Mm-hmm.
ago. People take out full paid ads blaming the other guy. It was like, wow, is that really where we want to go? Because here we are today. We're in an arms race on AI. And right now, the providers are winning, in my humble opinion. They have better tools at their disposal at the physician to more accurately capture documentation. And of course, they would claim more fairly be paid for the time and effort. Well, that's causing insurance companies to see a spike in medical loss and a huge increase in level 5 visits. Okay. We all, those, the E&M coding that goes on here. Really? There's just like, what caused these things to be more complicated? We know we worked on this with ED documentation and Power Note documentation. Better documentation yields better reimbursement because you can more appropriately code. Well, if we're going to more appropriately code where everybody's sicker and every case is more complicated, that means the insurance company has higher loss. Surprise, surprise, rates go up.
Premium. Yep.
Right.
Because look, insurance companies are programmed over time to not lose money. And it's not because they're terrible people, okay? Because that's the business model.
They're for profit, by and large.
Yeah.
And that's
Depends
okay.
on the
Blue
yeah.
Cross network. But look, the reality of it is hospitals are, if you go to HCA, you go to Nashville, they're like, we pay taxes, they don't. That's the difference. Okay. Everybody has a profit motive here, including your physician, your dentist, your PT company. And they're not evil because they want to have margin and have a good life for their family and get paid appropriately. But let's be fair. If we have to pay more for that, the insurance companies have two choices. Say no, limit your network to places that are willing to do it for less money, or raise the rates.
Just raise premiums.
And so this economic thing is not that complicated. And I would love to say, let's get payers and providers to understand that blaming each other has done nothing except destroy trust in this system. And healthcare innovates at the speed of trust. And as long as we're blaming each other, trust will be low, innovation will be quashed. And I don't think we get to better health, better care, better value.
So, Dick, this is, this is absolutely compelling and timely. I mean, with everything in the news, premiums are going up at the highest rate, at the highest speed that they've ever. We all feel that, regardless of what stage of life we're at. Two things that stood out to me. I was listening to another podcast, Stacey Richter, Relentless Health Value. Give her a shout out, and she was talking to a payer. And one of the comments that they made, and in all of the actors, the only person that actually has a fiduciary a responsibility to the person is the payer. And I have to admit, that just kind of made me sit back in terms of, the people in the health system that you interact with. The only person that actually has a legal fiduciary responsibility to me is the payer, and yet they're the ones who get most of the animosity
Yeah, I
put
mean,
up against them.
I'm sure the physicians and providers listening on this will say there is a duty of care.
There's a duty of care. That's fair.
And I think this is actually where I think if you put all of our duties, and a duty is something legally that we are required to do, right? When you see a contract says, the insurer shall, that confers the duty. And
Yeah.
so there are duties. And look, I think believe I could credibly argue the payer side of this and the provider side. And I have
Mm,
grown up working most closely with providers, and I'm committed to because at the end of the day,
same.
we all want to go see someone who's competent,
Hmm.
accessible. And accessibility has two attributes. One is if I can't afford it, it's not accessible. And two is I got to wait 6 months. That doesn't feel very accessible either. Okay. And even people with good insurance can't get appointments to specialists. And so, we've got a lot of other things to unpack and to improve here. But I think rule number one is healthcare innovates at the speed of trust. Two, I think we are destroying trust when we blame each other. And I think we need to call a national truce between payer and providers and talk about what are the systems that need to be in the middle
Hmm.
that improve the workflow. You hear this on prior auth. Look, insurance companies have gotten rid of prior auth for huge amounts of of cases at huge amounts of providers. And I don't have all the data on this, but utilization does tend to creep back up. Okay. And so somebody has to be watching because, surprise, surprise, not all healthcare that is provided in America is necessary either by clinical acclamation through the American Academy of something something, or the Medicare or the national approaches we take to the preventive health task force. I mean, we just have to be honest with ourselves. We actually sometimes waste money and we do things that are probably not indicated for better health, better care, and certainly not for better value. So, those are two ideas I have that I think, and to me, you know, I won't use the word, but in Mars, Matt Damon plays the astronaut that is stranded, and he says, "I'm going to science the crap out of this." Right?
Yeah,
Mhm.
right.
And my answer for healthcare is, we're going to innovate the hell out of this. The answer is in innovation, and innovation will thrive if we can build trust. There are so many good ideas out there. Most of them are going to be left at the altar because we don't trust that I benefit, they benefit. And so I think we have to establish a new trust framework, which is, it's the trifecta. I benefit because guess what? It's about me, it's about my family. Providers have to not be disadvantaged, and hopefully they benefit. And the payer can't be the one left out in the cold here. And then there's all the suppliers, pharma, med device, information services that surround it. I think, let's just agree to stop blaming each other for a while. And I think we might actually be able to innovate at these intersections in a way that would be meaningful for everyone.
Well, I also think that, part of the innovation is you're seeing in a way that was not feasible 10 years ago, specialization in clinical workflows. So I go back to, I think we all read the book, Clayton Christensen's Innovators Prescription. And by recollection, one of the things that he talked about is creating these centers of excellence around disease states or condition states that could really optimize how you care for said a person, optimize the value, and then they would compete on the value, not just the care delivery, but also the price delivery. And I think of companies like Time who are focused on oncology and cancer care, even companies like a Sorge or a Hinge that are on
Hmm.
the MSK space. And there's a whole host of these that they're they're not so much competing per se with the health system, but they're augmenting or creating a dedicated experience around a specific condition state, and then they're competing on the value that they can provide on the outcome of that condition state. And I feel like you probably saw a host of those conversations at Health, I would imagine. I feel like that's almost part of the future of changing this dynamic of creating not fragmentation, but more specialization, and where you can compete in each of those areas on both value and outcomes, if you will, differently than more of a holistic integrated
Yeah, and
system.
I my investment thesis is innovation in the post EMR world.
Yeah.
We're fortunate. The government put a bunch of money in companies like Cerner and Epic and Meditech and eClinicalWorks and NextGen and Greenway. All of us benefited handsomely in the infusion into
Hmm.
the provider space, the acute and the ambulatory. There was no meaningful use for public health. There
Yeah.
was no meaningful use for behavioral health and well-being. So, of course, we see that gap in many
Hmm.
aspects of healthcare that still lag on the digitization. But that alone, the specialization, I am a fan that a lot of the innovation is coming at these, they're not silos, but they're specific areas of a healthcare need. And I think that's working. Okay.
Yeah.
The question again is, now you're going to go seek care um, at the best place for your particular condition at that particular time. And the health systems all want you to stay in their system,
And
right?
that's right.
Right.
Yep.
Hmm.
And that's a proprietary view to my health. Now, in certain communities, the only game in town, that's a pretty obvious approach. But in a lot of other places, you're going to seek out what's the best. Well, who knows what the best is? So lots of companies have tried to figure that out. I actually think I don't think we've activated on the information blocking rule fully and the price transparency rule. But I think this is where AI is the game changer. Trying
Agreed.
to integrate any of our your listeners that would have tried to integrate the price transparency file or to do the aggregation of medical records across the community on behalf of the patient, not on behalf of the provider, which is what HIEs have done. You know, they found it to be pretty challenging. Okay. That's getting, absolutely order of magnitude easier. And I think will get easier again by another order of magnitude. So I'm feeling that the technology that allows what I would call, the health system of Doug. So Russell and Doug have a new health system. It's called Doug Health Inc. And it's going to help you manage, and it's for your family. And we will finally put together a health system that's actually tailored to you. If you look
Hmm.
at the rolling around, the new way to do the 401k for healthcare, the new benefits approach. We have a great company in Kansas City that's working on that benefit bay. And of course, we have Lockton and CBiz and lots of other folks that really help do those things, plan design and others. Now, when you look at that, Doug Health Inc. is now a possibility. We know your health history. We know your health journey. And, we have a different story than Russell Health Inc.
Hmm.
So I'm very optimistic that if we can stop fighting and we start to say, how do I build the health system of Russell? And Russell, I don't know if KU builds that for you or if St. Luke's Wash U builds it for you or if United or Elevance or Anthem or whatever, the dance card of names Humana builds it for you. But I think that's the opportunity. And companies like what Bill Turpin was doing or is doing in Columbia
Hmm.
Biography Health, that's taking a phenotype genotype association approach. The reality of it is most Americans are not going to be able to afford a concierge review of their health situation today. But why not? Is that not the Medicare annual visit? Why isn't when I turn 65, someone shows up at my house, we do the genetic profiling, we talk about my risk for the next 25 years and get that plan? That's part of what they're trying to do. But, that's been one of the most highly criticized aspects of the Medicare Advantage program. So let's call the truce. Let's get together, stop the blame game. This is going to be an incredibly difficult system to do a systematic change. I don't count on that. Let's change it around the edges. We've got systems of record in place at most of healthcare with EMRs. Whether people want to go out and replace their EMRs,
Yeah.
do whatever you think best with your tens and hundreds of millions of dollars. I think we have enough infrastructure in the country right now to power the change.
Yeah.
But, that's a whole different topic for a different time.
I think it's appropriate to call it a truce. I mean, it does really feel like right now a bit of an arms race with these two combatants firing up the AI engines and mobilizing technology to go at each other. And it's very concerning. And I appreciate you just calling it out. And the only way to stop it is to just call a truce. And let's communicate on the things that we really want to do better and not the things that don't benefit the system overall.
And I would really like to start better health, better care, better value. And I would like a recognition that we've built a health system we cannot afford. I don't know why that isn't a starting point with every national health conversation. I've done these presentations for years, and I'll give you an example that is people at the national level are like, that's not that big a deal. So, but immediately go to our debt is serviceable. Yeah, $900 billion a year is higher than the defense budget is servicing our debt. And much of that money, I know we owe it to ourselves in some cases, but a whole bunch of it goes overseas too. But here's an example of healthcare crowding other things out. Okay. States, 38,
Hmm.
39 states have a balanced budget amendment. The others essentially have to catch up at some point. We do see some states running real deficits when you put their pensions and other things. But let's just do the accounting. So you're a state that maybe took, maybe didn't take Medicaid expansion.
Hmm.
But if you look, Medicaid's the runaway train in terms of you don't really know all the, and then there's all kinds of plans to try to manage who stays on Medicaid and the requirements to get on and stay on. And you know, Some of that's reasonable. Some of it I think is probably interest to some families. Hopefully we can find a middle ground there. But the states, they just have to pay for it. Federal government subsidizes that, sends money back based on all these crazy formulas. Some states get more, some get less. But you can track the rise of Medicaid spending by the state, excuse me, and a decrease in three things. The data is clear. Number one, we stopped spending on infrastructure, roads and bridges, ports. And now you get these, Society of Civil Engineers, giving us a C minus. Little self-serving if you're in that business, but I get it. I think it's probably right. Two, recreation, parks, the things that we used to say value and quality of life. Number three, higher education. So it wasn't that long ago, you could go to your university of name your square state or, whatever it happens to be, and you could expect to go for all in for under $10,000 and get a world-class education at your state university. I don't care about private. They do. I mean, I care about private, but that's not a controllable price. And the accessibility needs to be on the public education side. And you know what? It was not that big a deal for states because we would allow people to take out these loans, including the federal government would give you plus loans for
Hmm.
parents to indebt themselves in addition. And so now what do we have over the last 20 years? Surprise, surprise, a student debt crisis, both graduate and undergraduate. That is a direct result of an expanding higher education enterprise. I'm on two higher ed boards. I love higher ed. I think it's what changes lives. It's what changes the trajectory of families out of poverty and into, goodness around the world. But we've created so much ability for those universities to charge exorbitant prices for housing and food and tuition. We say, oh, but that's not actually what they pay. No, because you have these people take out all these loans and they're not dischargeable. So we have an entire generation of young people that have paid too much for higher ed, are burdened by that debt, and you can trace it back. Look at the data. The rise in healthcare spending, which the states are increasingly responsible for, the decrease in roads and bridge creation and wellness within a community, and funding to higher ed. That's where it has to go. And we don't see it at the federal level because we just keep borrowing.
At the state level, it compresses.
State
Yeah.
Yeah.
level, they will have to do it in the next plan year. And they did, and they have. So I think the discussion starts. We've built a health system that we cannot afford. And the sad part about that is those of us on this call will probably get access to decent health care and our family because we'll find a way to do it. And there are people in rural America, people in urban settings, and people that are, employed at the early wage scales of most of Americans, and they cannot afford health care. And that is a tragedy in my mind. And if we could get the cost right, we could finance it more appropriately. And I don't want to get into healthcare as a right or a privilege. I think that is one of those unanswerable questions in some respects. But come on, guys. But for the grace of God, go I. You're injured. You get a disease. I mean, come on.
Yeah.
You're not a good or bad person because this happened. It just happens. We also know it's the single biggest cause of family bankruptcy. Well, that's great. So I've got some other proposals on how to solve that too. But, I know this podcast is not going.
So Dick, we're gonna certainly have to have a continuation of this discussion, but I want to go back to a couple of things that I heard you say. One, I fundamentally believe that the future is bright. There is innovation that's happening, innovation that can help
Boy,
both break down silos, break down information shared, that can shine a light on cost and transparency. I love the three phrases: better health, better care, better value. And I think we are all well served, whatever side of the equation, payer, provider, technologist. If those are our mantras, then we will have the right North Star in terms of ultimately what we're trying to build. And then lastly, I'll just pull it back to the Kansas City community. I could not be more excited around the innovation that is being fostered here, what Digital Health KC is doing for that. You mentioned a new company. I had to look it up while you were talking. Benefit Bay, they're in the ICRIS space. There's a lot of innovation there that kind of goes back to the payment discussion that we were having. I love to see that. End on a high note. Dick, this was a phenomenal conversation. As we close out, anything you want to give a shout out to either in KC or broadly before we bring this
Well,
to a
look,
close?
the last thought is we are very fortunate to work in the heartland, greater Kansas City region with so many talented professionals. And I've seen the companies that we talk to and we mentor and we advise have a genuine interest in changing healthcare for the good. And the first question we ask people, there's two questions when we interview is number one, what healthcare problem are you solving? That's an obvious investor, any question. The second is, do you have a good heart? And I know people have laughed sometimes, and it's like, look, we don't need someone else shuffling the reimbursement deck. I was in Nashville a couple of weeks ago, said the same thing. Come on, guys, let's work on the real problems that are in healthcare. Let's get the right information to the right people at the right time so that we can improve outcomes, better health, better care, better value. And I think we got to stop the financial machinations with hope that I know it creates value and I know companies can get big, but we want to work with people whose heart is to transform the system, probably around the edges, but it ultimately leads to better health, better care, and better value. So Kansas City's the place to do it, man. We got the people, we got the talent, we got the companies, and we got Doug and Russell. So what else do you need?
What else do you need? What else do you need? And we have Digital Health KC. That's really the trifecta right
Exactly.
there. Dick, this has been a wonderful conversation. You're always welcome back. Thank you. This has been the Counterweight. Have a wonderful, wonderful day, and we will see you again on the next episode.
Thank you.